joined, if you did just join, we are just asking that you either put your CCO name next to your participant name so that we know which of the 11 CCOs are here, or you chat in the chat function like Danielle, Rebecca, Josie, and Tanvir have done in terms of just putting your CCO name, and then that way we'll make sure that we have the 11 covered. But we'll get started in just a little bit. And then if you're not talking, if you could mute, that'll cut down background noise. And you can do that by, in the panel on the lower left side, there's a mute button.
Hi, this is Alan Burgess with AllCare, and I just want to weigh in. My internet went out, so I'm just calling into the meeting, so I can't do any of the chat.
Sorry. Yeah. These are the times, aren't they?
I know. It was like a half an hour ago, and I was talking to somebody else, and we were doing something over the phone and online, and then my internet went out, and I had to tell her I need to hang up and try and figure it out for this next meeting, but it hasn't happened yet.
Alan. Elena, do we have his email that you could send to me his email really quick, and I'll send the slides just so that if worse comes to worse and you're having to kind of look at your phone, you're not feeling like I don't know what you guys are talking about. Or you can see, you just can't chat, Alan. What would be helpful?
Well, I can't see anything right now.
Okay.
Colleen, I can just email the slides now. I have all the information needed.
Okay, I edited this morning again, so just take from today. Okay, sorry about that. We're all having to have grace around that, aren't we?
Yep, fun times.
I have 3 kids online learning, and I'll know exactly when the internet has gone out because there is a very loud yelling about something happening in the house.
Yeah, I know that because I expressed a couple 4-letter words when it went out.
Yeah, it's fun. It's a really fun process.
Anyway, so I'll be on the call and listening and all that.
Okay, thank you so much for your grit. We appreciate it. All right, I think I'm gonna start. Am I good to start, Elena?
Yeah, let's jump in.
Okay. All right, well, welcome to the first webinar for you all that are the CCOs that are agreed to be part of some of the input sessions and pilot sessions around the proposed CCO system level social emotional health metric. The focus for the call today is on one part of the metric and a central part of the metric, particularly in the first year, which is around the child level reach metric for social emotional health. So we want to thank you for agreeing to participate in the pilot. Your insight input is invaluable. This work builds off significant community engagement and some significant work in 13 counties. And your input and insight is incredibly invaluable at this point. For this call, I have the honor of doing most of the talking, but a number of my colleagues will also be stepping up to answer questions. And I really want to make sure that the breadth and depth of the team that's behind this effort are recognized. So my name is Colleen Ruland, and I am the director of the Oregon Pediatric Improvement Partnership. And I have my 2 colleagues that have spent an amazing amount of time on this work, Lydia Chang, who's our medical director, and Katie Unger. I'm sure you'll hear both of their voices, but I want to make sure that their contribution to this work is recognized. And then this is an amazing partnership with the Oregon Health Authority and the Children's Institute and Sarah Santos Consulting Company. So specific to the data we're going to be talking about and the reports that were provided to you early in the week, I want to make sure we really honor and acknowledge the hard work of Andy Parker, Frank Wu, Valerie Stewart, Laurel Dennis, Nikki Olson, and then just broad and deep support from the OHA Health Analytics team. And then our co-partner in crime in this work is Elena Rivera from the Children's Institute, who is going to be helping today monitor the chat, pause, and make sure that I answer any questions. I know you guys are getting a lot of emails from Elena, given Children's Institute's critical leadership role in this work. And then we have also contracted with Sarah Samsel, who is helping develop, in particular, a lot of the deep work around the attestation metric, which will be the components of the future webinars. So thank you, team, and I want to make sure that you recognize how deep and broad this teamwork is to make this work happen. So in terms of our agenda today, I wanted to make sure that we first did a refresher, a 1,000-foot view of what are the components of the proposed system level social emotional metric. And then we're going to spend a deep dive on the call today, the focus of this first call, on the social emotional reach metric and kind of what it took to develop it, what construct we use, what parameters we use, the kind of work we did to develop the codes that are noted within the numerator of the metric, so what counts as a social emotional health service, and then descriptive information that you should have received in the reports provided to each of the 11 CCOs for each code, and kind of descriptive information about where that sits and kind of some of the 0 to 5 diagnostic crosswork that is noted and the prioritized list line. And then I want to walk through the data that you received and kind of why there are different time periods. I know that's probably confusing, but given this is a pilot, but also given we wanted to be able to give data, we wanted to pull from what was available and also pull from what we knew would be meaningful. And then we also just want to be able to ask some questions from you about proposed process we might consider related to that reach metric. And then we have in particular a set of questions that we would love to get some input from you on. Particular questions that relate to whether and if we include codes that are below the list in terms of currently funded as of 2021, and then whether we include some of the codes that require provider taxonomy. And then we'll end with a highlight of what's going to be the focus of the March 18th call, and my colleagues Elena and Sarah will spotlight that. So that's our agenda. Again, if you joined late, please, one, either put into your participant name, your CCO, or just put it in the chat like a lot of your colleagues have done. And then that'll help us make sure that we're tracking which of the 11 CCOs are on the call. And then if you're not talking, if you could come, please mute or mute your phones, that'll help cut down on some of the background noise. So big picture, 50,000-foot view, as you've heard at a number of TAG meetings in which I think the presentation of this pilot was presented, this work really builds off years of work that have been done in collaboration with the Children's Institute and the Oregon Health Authority to help facilitate the health aspects of kindergarten readiness measurement work group that confirmed and finalized a 4-part measurement set that was then endorsed by Health Plan Quality Metrics and Metrics and Scoring as a strategy. So the 4 metric sets, the first 2 are already in the incentive metric set. So preventive dental for children, which has actually been modified to be preventive oral health for children 1 to 5, well-child visits for children 3 to 6, this system level social emotional metric that we're talking about today, and then in the future, follow up to developmental screening to kind of leverage and build off that work that happened between 2013 and 2019 to increase developmental screening rates to have Oregon be one of the top states. That metric would actually focus on making sure that children identified at risk receive some level of follow-up services. So the focus of today's call and the focus of this pilot is on that 3rd metric, the system level social emotional health metric. So as you guys have been hearing, and I'll just provide a brief refresher, again, you can look at the TAG presentations, the metric and scoring presentations. If you need any copies of those, just put that information in the chat and Elena can follow up with examples of those presentations for you. So in terms of the big picture vision of this system level social emotional metric, the vision is that children from birth to age 5 and their families have equitable access to services that support their social emotional health and are the best match for their needs. One of the kind of consistent, persistent, and unanimous areas of focus of the health aspects of kindergarten readiness work group was that there needed to be something that focused on social emotional health. The purpose of this system level metric is to drive coordinated care organizations to address the complex system level factors that impact the services that kids and families receive, how they receive them, and for which there may be payment or policy barriers that need to be addressed. This metric, as was described in the presentation to metrics and scoring, addresses a gap in the CCO incentive metric set. There is no metric that actually focuses on behavioral health for young children. And this actually represents some other components of care such as integrated behavioral health and coordination with early learning systems that's not represented in the current set. So the purpose of the system level metric is to ensure that there are activities and that you receive transformation funds when those activities are completed that really help you to build capacity within the CCOs for enhanced services, integration of services, cross-sector collaboration, and then to identify future measurement opportunities, in particular a child level metric that could ultimately replace the system level metric. That being said, we know that there's the power of being able to look at metrics, and there's a power of being able to use data to guide and inform your efforts. And so today's call is really focused on a component of the metric that is using child level data to guide and inform those activities, those transformational activities that would address some of the system level barriers, and to ensure that that child level data is sensitive and specific to the improvement efforts that you may implement. So as Elena shared on our metrics and scoring presentation, this proposed measure really builds off significant amount of work that's happened in rural I-5 corridor and other areas of the state, and has really been informed by a broad and deep cross-sector representation, which includes families, healthcare providers, early learning providers, and cross-system level leaders. As an OHA, OPIP, CI team, we then took all that rich fodder of community level feedback and also community level proof pilots about whether improvements can occur, and then generated a list of themes focusing on the outcomes desired, and affirmed those themes with stakeholders. And then we had to do the really hard work of kind of figuring out how to prioritize of all the things and all the areas and opportunities we heard from various people, what were the most important ones to put in the metric so that it is parsimonious, feasible, and actionable for you as a CCO. We recognized that we couldn't put everything in that people wanted. So we really narrowed down to the places where there was really consensus across stakeholders, for which we had demonstrated proof pilots that improvement can happen, and for which we knew there were the largest gaps and opportunities for improvement. So in order to make sure that we were informing the work that was aligned with stakeholder feedback, but also really thought about the kind of like unique attributes of a CCO level metric and the unique attributes of what would be something that's feasible, meaning and relevant for a CCO to lead, we then developed design parameters that helped us kind of think through how to narrow those activities, develop measure specifications, and think about the lever of a CCO incentive metric to kind of push on some of those activities that would then guide to the levers and activities at the front line that would relate to improved outcomes for children. And so then after that, we created the plan for piloting the metric, did the data analysis, and this is where we are now. So at a high level, how the metric works, and again, we're then going to spend a lot of time on one part of the metric. This is a visual you've been seeing where in year one, so we're proposing for adoption in 2022. In year one, there would be two components. The first is using the claims and utilization data provided by OHA to understand current access to behavioral health services for young children that really span the breadth and depth of social emotional health services. The second is then leveraging and using that data to then assess community assets that could support social emotional health for young children. So as you saw in your data, there's a gap that there's majority of children have not received a social emotional health service. So year one really then focuses on, okay, well, what are the services that exist in your community? Where is the gap, and how might you think about addressing that gap? Years 2 and on of the system level metric then focus on specific activities, again, informed by the improvement pilot and informed by stakeholder feedback about the primary barriers that would then focus on specific interventions that would address community engagement, workforce, access, care coordination, and payment. Throughout years 2 and on, the data would continue to be provided, and we would continue to be looking and seeing if it was sensitive and specific to some of the improvement efforts. Knowing that the ultimate goal is to replace the system level metric with the child level metric in alignment with the health aspects of kindergarten readiness work group recommendations, and in alignment with some of the proposals that were put forth to metrics and scoring and health plan quality metrics, and part of their approval and endorsement of the 4-part measurement strategy. So today we're focusing on the green boxes. And in future calls, when we talk about this attestation metric or part 2, part 1.2. That's the focus of the March calls. Okay. So talking about the social emotional services reach metric. So again, it's a child level, person level metric. And it's really meant to capture a range of services provided across the spectrum of providers. And it's also meant to galvanize and potentially inform innovative billing by early learning providers. This was a high priority area called out by our health aspects of kindergarten readiness work group, and in particular by some of the early learning sector that was represented on the work group. So again, if you look at Bright Futures recommendations, all children should receive at least an assessment of their social emotional health in the early years. And then there's a group of children who would then benefit from services that would either provide brief interventions addressing diagnosable risk factors for which there is evidence that services can have an impact. And then services also for children who have diagnoses that could then be beneficial in enhancing and addressing those social emotional delays. So this reach metric includes all three parts of those. It includes assessments and then includes services. Again, services that according to claims data could be provided in an array of settings, integrated behavioral health, specialty mental health, and then there are claims that home visiting could potentially use when paired with a diagnosis that would indicate it was a social emotional service. So we included all applicable codes that were valid, aligned with evidence-based, aligned with appropriate steps for social emotional services, and understand that there are some claims not currently used. And that may be a place that you as a CCO think about, if we have this opportunity, if we have these assets, maybe that's a strategy over the time of how we might think about some system level policy payment barriers that we could address in order to allow those services to be billed and those services to be provided to children. So in developing the measure, we first went to look for, is there a measure already available? And then can we just take that metric? And Oregon has been part of the Center for Healthcare Strategies Aligning Early Childhood and Medicaid efforts. And then Oregon has been part of a number of other efforts, such as Assuring Better Child Development, in which we're able to talk to a number of other states. And there was no off-the-shelf metric that we could take and use. And I think this is actually for a number of reasons that kind of lead to why Oregon's so innovative. The first is, we're really trying to capture social emotional health services that are provided in primary care aligned with Bright Futures, but also likely aligned with high quality patient-centered medical homes. And so I think that's an area of opportunity. We're also trying to capture the invaluable kinds of services that happen in integrated behavioral health. And that's not something that exists across the country, nor for which there's clarity of how payment occurs. And so I think that's a potential other barrier. And then the third is we're talking about behavioral health, evidence-based behavioral health for young children. And most of the metrics that exist are focused on adults, which is again why health and quality metrics and metrics and scoring are so interested in this upstream metric, because it's trying to think about how do we address early children that we know have experiences and children that we know have needs, that if we act early at the time that their brain's developing, then we can actually help them to be ready for kindergarten and potentially help avoid some of the long-term behavioral health needs that we see on the adult side. So we started with stakeholder calls with national experts. We built off review from other metrics, such as the NCQA mental health utilization metric, which is a different metric designed for different purposes, but has some valuable things to pull from. We also pulled from Washington State Department of Human Services mental health utilization metric. Again, a different metric for different purposes, but some great things to pull from. And then we also kind of made sure to align with covered services and diagnoses in Oregon by looking at the Oregon 0 to 5 diagnostic crosswalk, which you should have received a link to in your pre-meeting materials. If you didn't and you want Elena to copy and paste that into the chat, happy to do so. We wanted to think through kind of appropriate, billable, reimbursable, integrated behavioral health services that can be provided in a primary care and that are aligned with primary care payment reform collaborative recommendations around behavioral health services. And then as you saw, and as a key area we want to talk to you about, we did note currently where those claims and codes are in terms of on the prioritized list. in the REACH metric that you see today, we included all applicable codes. There is a handful of diagnoses paired with specific services that are below the prioritized list. It doesn't yield actually a significant difference in the REACH metric findings, but it's one of the places we really want CCO level input. And so it's going to be a place I'm going to ask you later on for your input on, and that we'll be asking for input. You can provide it after the call. This work, I have to give credit, was from a conceptual point of view, really led by my dear colleague, Lydia Chang, in terms of doing a lot of deep work. And so we're incredibly thankful for the various stakeholders reviewing it. We're thankful for our partners in Medicaid and the Child Behavioral Health team, and in the Early Learning Division and the Oregon Health Analytics Division for reviewing this. We are currently having another round of review by folks within Medicaid, just because, again, this is a novel metric. So, you know, we're trying something that hasn't been done, which is, again, was part of the reasoning why the proposed incentive metric for adoption in 2022 is the system level metric and being able to attest to specific activities. The proposed measure for adoption in 2022 is not that you improve on this metric and then incentive money is tied to improvements on this metric. The proposed measure is actually that you use this data so that we, one, can understand the value, we can understand any potential issues with it, and we can also understand its sensitivity and specificity to improvement efforts, knowing that we have proof pilots that demonstrate that it is sensitive and specific, but want to make sure that we learn that over the first year should it be adopted. And then the metric was also reviewed by the Center for Healthcare Strategies and their contracted experts, which are providing support to the Oregon Health Authority team that's part of the Aligning Early Childhood and Medicaid efforts, or ASEM efforts. We provided a link to that website if you're interested in learning more about that. This work is a particular spotlight of Oregon's approach and Oregon's strategy. So in terms of the REACH metric, the Social Emotional Services REACH metric, the numerator is children who are 1 to 5 who received either an assessment, and again, the recommendations are actually for all children to really receive some level of an assessment, or who received a service. If children receive both, if they received an assessment or a service, then they get a point, because it's basically whether they got either or both, or sorry, either. They didn't need to get both. And then the denominator is children that are attributed. And in the data that you received, because we're trying to give you data currently available, you'll see different levels of continuous enrollment requirements because of the different data elements. But the proposal is that it would be one that's aligned with other NCQA metrics, aligned with other CCO incentive metrics that you have, which is that it's children that are continuously enrolled for 12 months. So to allow you that 12-month period. And so what you saw in the materials is that there are these two components, component A, which is assessment, component B, which is services. So within assessments, there are 2 lists of codes that were used. And again, those 2 lists were provided. The first list was behavioral health assessments that are clearly behavioral health assessments. You don't need any other information about that claim to know whether it should count as a social emotional service and a behavioral health assessment. The second is, and again, in our attempt to be as inclusive as possible, are assessments that are broad, that you actually don't know if that assessment is specific to social emotional health services. And so in order to make sure that it could count, but also in order to be as inclusive as possible, we added in list 2, which are assessments that when paired with a mental health ICD-10 code and provider taxonomy could count as an assessment. Again, there's not a lot of children who are identified in this way, but we had wanted to be as inclusive as possible. So list 1, list 2 comprises component A, which are assessments. List 3, list 4, and list 5 comprise the kinds of claims that would align with services that address social emotional health and delays. List 3 are services that are clearly services related to social emotional health. List 4 are services that could be related to social emotional health. And so the way we clarified whether they were is, again, if they were paired with an appropriate mental health ICD-10 code. And then the last set is services that could be if paired with the mental health ICD-10 code and the provider taxonomy. That's list 5. So later on, when I ask you questions, I'm going to ask you questions about list 2 and list 5. Again, there's not a very, very small amount of kids that are identified by list 2 and list 5. But our strategy was to be as inclusive as possible, given that when those things exist, that they could be considered a social emotional health service. So what you received in your packet was actually the list of each of the codes. So I'm just going to spotlight ones that are listed on the left of like, these are the kinds of codes we're talking about. Again, one of the strongest recommendations and guiding forces and North Stars of this work from the health aspects of kindergarten readiness and from the hundreds of people who gave us feedback was that this measure needs to galvanize, support cross-sector efforts, and needs to think about the breadth and depth of the kinds of people who can provide social emotional services. And that can include things like primary care providers, that can include integrated behavioral health, that can include a broad spectrum of providers. And so when we were thinking through honoring that North Star from the committees, that was a really important component of the work and a really important design parameter of which codes and claims we included. So you have that list 1, which are assessments that don't need a diagnostic requirement. So I think it's probably pretty clear, 96127 is a brief behavioral and emotional assessment that may include any standardized screening. So we clearly didn't think you needed to have a mental health diagnosis tied to it. In terms of the assessments that would be required taxonomy are ones that are not specific to social emotional health, but when paired with a diagnosis could actually be valid for a social emotional health service. And then list 3, again, then you're going into that component B, which is the services. So again, these are services that we did not think needed to have a mental health diagnosis because they're clearly social emotional services. And then list 4 and 5 are ones for which there could be social emotional health services provided if we knew that they were being provided for specific diagnoses, appropriate, of course, for young children. And then again, by specific providers that would indicate that was appropriate. So you should have kind of each one of those lists exactly what went into it, any information about the 0 to 5 diagnostic criteria, and then again, where relevant, the prioritized list line. So we developed this measure in 2020. In 2021, in 2020 there is retirement of codes like the health behavior and assessment code, like the developmental testing code, and so we plan on adding in the codes that replace those components and updating the metric. Obviously, as there is look back period, so some of the reports that you had 2016, 17, 18, 19 data. We're obviously going to use claims that were appropriate and countable in those time periods before there were some of these adjustments. Again, a number of these codes are things we're going to be watching and looking for, and we would love any insight and input from you on that. So before I walk through the reports that you got and what is in there and why they're put there, Lydia, do you want me to, I think somebody maybe doesn't have their thing on, or thing, that's the right word, your computer on Zoom, so I'm just hearing a lot of background. Lydia, my co-partner in crime, anything that you wanted to add from a clinical perspective in terms of the deep work on lists 1 through 5 that I didn't cover in the overview?
And I think she might be traveling, Colleen, so
Oh,
I don't.
okay. Okay. Sorry. Thank you. Okay. So let's walk through the data. So in terms of the data report, again, thank you so much to the Oregon Health Authority for all the great partnership work. Using the claims and codes that we described, this is the state level findings for the social emotional reach metric. So you see there hasn't been a ton of movement between 2016 to 2019. And again, this is part of the reason that this is being proposed as a lever within the incentive metric set, because there's been a lot happening for young children in your communities And so the kind of concept is like, this is a really important opportunity for healthcare and CCOs to play a unique role to address one of the primary areas that health aspects of kindergarten readiness identified as a need and an opportunity for CCOs to help contribute to some of the factors and the barriers to why children aren't ready for kindergarten. And so in 2019, the average rate across the entire state was 6.46%. So that's the state level findings. And then at a CCO level, again, we knew of 2 specific CCOs that were doing very targeted efforts between 2018 and 2019 and wanted to see was the measure sensitive and specific to those improvement efforts. So overall, you're seeing there's not a ton of movement and improvement, but you are seeing that there actually were some CCOs who did have some levels of improvement. And those were ones for which we knew had targeted improvement efforts that were really focused on this topic area, which again was a good sign that some of these efforts are sensitive and specific to the kinds of measurement that we're trying to propose. And so you should have received in your report your own dotted line in terms of right now, obviously, on a call across the CCOs. We're just showing you the blinded level findings across the 15 CCOs, but you should have received for your CCO your own dotted line. For those of you that are new CCOs, there's obviously different reports that were provided to you because you were not a CCO in the region during some of these time periods. But you received some other data that hopefully can help you still understand what your populations have experienced and understand as you're starting in these regions kind of what kinds of experiences the children that are attributed to you have had. So as I mentioned, the measure counts assessment.
Excuse me, Colleen, this is Jean. Can you share where we should be looking to receive that individual CCO data? I just see what you're presenting is what I received, but I may have missed it.
Okay, Elena, what was the email that they came from, and then who was the person that it was sent to EOCCO?
So the Oregon Health Authority uploaded CCO level files and reports to your individual SharePoint, secure SharePoint site. And so you should have received a package of reports that also included like a cover letter memo and then different files with your specific CCO data. If for some reason you didn't, please let us know and we'll make sure to circle back with the OHA team.
I did not receive anything from OHA, but I can check with my CCO. And where would it be like living that nobody may know?
It should be in the metrics dashboard, the CCO metrics dashboard on your SharePoint site.
So Jean, you have contacts in your CCOs that have access to that site. And so because that's how, according to data use agreements, OHA can share that data, they have to share it with the people that have access to that site. So Frank, is there a list or by CCO? I know in my experience, I'm not sure if OHA knew exactly who that CCO designated, but Frank, is there any way Jean could know who in our organization? Maybe you could chat her on the side and tell her.
Hi, Colleen. This is Jen Davis with OHA, and I can just let you. Yeah, I can let you know that it's Callie Payne is the main contact at EOCCO that has access to the SharePoint site.
Great, I'll email her right now.
Okay.
And just to make one more clarification, Frank is posting in the chat from the OHA team that the CCO specific files are uploaded in the same place that you would usually download your monthly dashboard, and the date at the top of the file is 2021 February 22nd. So that's how you would search for it. Thanks, Frank.
So again, the metric is meant to be broad and inclusive. I will say that the one place that when we had the hundreds of people complete the stakeholder survey about what we should focus on, the one place that every single stakeholder noted was, yes, we need to identify early. Yes, we need to do promotion. But when children have a need for services because they have delays, there are not services available that meet the magnitude of the need. And so, again, this metric is meant to be inclusive of assessments, and it's meant to be inclusive of services. Some of those services are brief interventions that are done early for reimbursable at-risk diagnoses. But there also are services that are included for children who have social emotional delays. And so we wanted to make sure that we're constantly looking at this of like, of the total rates, how much are actually based on assessments versus services. And so when we're kind of looking at some of the health complexity data match work, for example, which you will see later on in your report, we're constantly showing you, and you should see in your report, assessments versus services. And so when we're looking at that run chart data, for example, by CCO, you should see like, of my rate, how much came from services versus how much came from assessment. So one of the areas that we really heard from health aspects of kindergarten readiness was, of course, we want to raise the vote for all children. That is so incredibly important. But we also want to think about a health equity approach that's really looking at children for which we know there are historical inequitable outcomes. And we also want to be looking at children who are having experiences that are aligned with adverse childhood events, for which social emotional health services is one of the recommendations for addressing and building health and resilience for children with ACEs. And so data available at the CCO child level that could help inform some of these conversations and inform your engagement with community level partners, given I know it might feel overwhelming to start at 6% and think about how you're going to move up, is the health complexity data. And so that health complexity data has, in particular, one section around it that's the social complexity data that really highlights and illuminates a number of the factors that we heard from health aspects of kindergarten readiness and that we heard from health plan quality metrics and metrics and scoring are children for which we know have historical and equitable outcomes. And we need to start thinking about how we're going to target some of our approaches to making sure that their needs are met. And so in order to help you as a CCO think through how to leverage that data to inform your community level conversations, that's why the proposal is that the data provided by OHA would then kind of show you that data by health complexity. So again, the kind of power of the data is one, all children in a sense should receive social emotional health services. But one might think of the health complexity data as helping you think through children who have already had adverse childhood experiences and for whom you may target some of your engagement, coordination, and collaboration with system level partners and local level early learning cross-sector partners. And this data could be useful in kind of guiding as a tool. And so what we're so thankful that the Oregon Health Authority in partnership is that you as a CCO get blinded social complexity data that tells you how many kids with a number of experiences are getting services. But we thought it might be helpful to actually have row unblinded aggregate level data that would just help you be able to engage with some of those partners that serve those children and really think about a targeted community-based approach for how we might think about those children with historical and equitable outcomes. And so the only way we can do that is to show you in an aggregate report, because giving you this child level information of this child had this service or this child had this specific risk factor wouldn't be in alignment with the data use agreements that make this data possible to be able to be shared. And so one of the really important parts that was provided to you is, again, you have the global blinded count of social complexity factors. And so while we would hope that children who have 3 or more of those factors would have significantly more access to just assessments or services, we see that it's still about 9 and 10 that didn't. So only 11% of children who had 4 or more of those social complexity factors have had a social emotional assessment or service, 4.1% had 1 or 2, and 1.77 had none. And then if you look at it by assessments versus services, these are some of the factors that kind of lead you to some of those places. But what is really exciting that the Oregon Health Authority agreed to share, again, in an aggregate report to inform some of that community level engagement, which is a component of the year 1 attestation metric, is the person level findings. If you found in any places in your report that it was blinded, so for example, substance abuse, there's a very small number of children, thankfully, birth to 5, who are receiving substance abuse treatment services. Most of them who are children who have neonatal abstinence syndrome. And again, because the ends get too small, then they violate data use agreement. So if you have those in your reports, the reason it is missing is it went below a threshold of a denominator for the data use agreement. But again, this could be a really helpful place to kind of think about, wow, you know, one might say children who have ever been in foster care in their first 5 years of life would clearly benefit from even an assessment of their social emotional health. And so that may be an area you decide to say, whoa, like this is actually a really interesting thing for us to think about that only 23% have. Or as we think about kind of, for many of you, you also are covering the adult and thinking about that adult with substance abuse treatment services, knowing that that is an ACE. Looks like only 9 out of, or less than, or 10% of kids whose parent have been accessing substance abuse treatment services have received either an assessment of their social emotional health or services that would actually help to address that ACE. So that was the purpose of trying to give that report to help inform the community level engagement and system level thinking that is really the backbone of the attestation metric. So in terms of the data that you got for this pilot, which again, we have these 2 months for the pilot, evil of good is perfect. We wanted to be able to give you things that would be helpful and inform the work, but also things that are available and timely, given that we're doing this pilot in these 2 month periods. So what you received were 3 different things. The first is a child level data file for those children attributed to you. And then the second and third are aggregate reports that give you reach metric findings over for the 4-year period. Again, if you were a CCO over those 4-year periods. And then aggregate reports that show you that reach metric finding by that social complexity data that I just showed you. Again, that's not something that can be provided at a child level per the DUA. So what you have in the child level data file, and again, this is amazing work led by OHA, thank you, Andy, Frank, and team, is the reach metric findings overall, and then also by each of the categories in the list that we talked about. Then in the aggregate report 1, you have the reach metric findings overall, and by whether it was assessments or whether it was services or both. And then the aggregate report number 2, and the reason it needs to be a different report is because it's a different group of children, is the health complexity data. And so we had to pull from the health complexity data available at the time of this pilot. And so again, that's kind of showing you those factors. And again, that's the reason for some of the sample size differences. I really want to know when you're like, why is it one rate versus another rate versus another rate, is because we were trying to pull from data available, and also because the child level file can be only for your attributed population at this time. There are different time periods and different enrollment periods used. But again, we thought we're trying to give you a sense of what this data could look like and what this data has the opportunities to do, knowing should this metric be in, should the full set of the metric, this being one part of it, be endorsed by Metrics and Scoring for 2022, there would be a concrete package for which things would be lined up, obviously. So the really important thing that is in your data is an overview page that describes kind of like what time periods, what continuous enrollment was used. So that'll help explain why there are differences given the time that we were pulling them. You know, should this system level metric be adopted, there's going to be a process by which we will talk through and learn from you about the best way to time the data, and then processes to support validation. Our thinking currently is that the data would be provided early in the year so that it could be used to inform some of those transformative activities at the community and system level over the time period that would inform your attestation, so that it could be really the first step of the work, and then kind of move it forward, given that the reach metric that we're talking today is not what we're proposing the incentive dollars be tied to in terms of improvement. We're proposing that the attestation metric and responses to the attestation metric about how the data was used and what kinds of activities were done is what is actually used to define that you met the metric and therefore could be eligible to receive the incentive funds. So the page that I'm talking about in your report is this cover page that was written by Laurel that kind of describes all the different important components in terms of the child level, what claims data was used, what enrollment data was used, in terms of the 4-year period, which we wanted to show you, the 16, 17, 18, 19, what period was used and how. And then because the health complexity data is pulled for a snapshot or a population file, this is the other component of it as well. So before I dive into our questions for you, are there any questions that you have for us about what I've gone through in terms of the construct of the measure, the details of the measure, and then what's included in your report?
Colleen, there's one question in the chat. I know that CCO should have received their reach metric data by health complexity, but somebody has asked when the new health complexity data will be released. I think the broader health complexity data.
Right, because there's a commitment from the Oregon Health Authority to release it annually. I think that is a really good question for the Oregon Health Authority, as I understand it. And so I'm just sharing what I understand now, but this is not a final decision. In 2020, we modified to using the all payer, all claims database because it could then capture for children enrolled in Medicaid, their primary insurance, which may be private. And as those of you know, there's an important group of children with medical complexity, which is one component of the health complexity data, that are eligible for CHIP because of their medical complexity. And so if we only look at Medicaid claims, we would be missing a really important lens of their medical complexity. So in converting to the all payer, all claims database, in 2020, we were able to get the reports out and use that data. OHA has subsequently since changed their vendor. And so as I understand, the all payer, all claims data would be available to OHA to run the updated health complexity data in summer of 2021. And so as I understand, the current game plan is to update the reports then. The best people to ask are, I think OHA Health Analytics has a global email that you could send a question to. And then I could make sure, if you CC me on it, I could make sure that it's raised at our health complexity data meeting. Any other questions?
I did just put that OHA email into the chat box so folks can reach out directly.
Okay, this is your chance to ask me questions before I flip the table and ask you questions. No questions? Are you all in shock that I could talk that slow? If any of you know me well, that was like that was a slow pace for me. So I'm really proud of myself. I usually talk a lot faster. Okay, then let's dive into our questions for you. Help us learn. So here's the questions that we have for you. Thank you for being the pilot participant. The point of being a pilot participant is helping us understand what needs to improve based on your feedback. So I'm really hoping that I actually hear from all 11 CCOs because these are authentic questions that we have about the actual measure. So again, big picture framer, the first part is assessments. The second part is services. There are 3 lists within the metric. List 2 and list 5 require a diagnosis and a provider taxonomy. List 4 just requires a diagnosis, again, all of which are appropriate for young children and not necessarily requiring diagnoses of a delay or disorder. They do include the at-risk diagnoses that are appropriate for the kinds of things that you would identify for children with social and emotional health needs. So 2 factors that we are considering in finalizing how this REACH metric is done, and if we think about adoption in 2022, in finalizing like what would be given to you if it were to be adopted as a measure, are listed here. I want to make sure that I'm like, disclaimer, you know, we're representing these as really important questions because I don't think that there is a right answer because there's people that could go up, do the pro column for each strategy and do a con column for each strategy. You know, I will share as of right now, we have looked at the measure not including both of these, and we have looked at the measure including both of these. And it's a very small number of children for whom this impacts. So this isn't going to lead to rates going up to 10%, and this isn't going to lead to rates dipping to 2%. This is very small number of children that we're talking about. So the first is, you know, we have certain claims and codes that are paired with a diagnostic pairing. And so we have this decision, right now they're included. And so we have this decision about when we have, and it is provided to you in the overview that was sent, we have a handful of diagnoses and services that are beneficial, that we know would be appropriate, but that are currently under the prioritized line for funding. So we have 2 options. Part 1 is to keep with the way we have it, which is we're including them because they are valid and important social emotional health services. And part 2 is don't include them. Don't include in a REACH metric something that CCOs are not required to cover. And this is age-old debate. And so one I would love to hear include or not include. I think I'm actually going to have people give a thumb up or not, or get back to us so that we can make sure that we hear from all 11 about this. The second is that list 2 and list 5 require provider taxonomy. And currently we're including them, and we're including them because we want to be inclusive, even if it doesn't capture a large number of children. And in the rare circumstances that those are used, they're really invaluable catches. So, you know, for one of them, it's inpatient, like that something happened and a psychiatrist saw that child and started that child on some of that journey. And so we wanted to count that, even if it's small, we wanted to count that. You know, one of the cons to not including it is, as I understand from my OHA colleagues, and this is something I have no deep knowledge on, is, you know, there is like barriers and limitations to how provider taxonomy is captured in MMIS systems or the quality of that data. And so, you know, you may be missing some of those. And as we know, what's measured is what's focused on. People might start coaching people on using these claims codes. And so we just recognize that, you know, it's not the perfect set of codes. It's also ones that we're trying to capture because they have face validity with the intent and goal of the metric. So those are the two areas that we really need to hear from the 11 CCO pilots around, like, where do you land on the include or not include spectrum of that decision that we need to make, knowing that currently they're both factors are included. So in terms of the diagnostic pairings and ones that are currently below the line, you know, you can see in the list, we've kind of provided where appropriate, not all of them require some of the prioritized list components, but there are certain conditions that, you know, when people who see young children know that, like, those conditions often can relate to behavior issues or social emotional issues that actually would be valid to kind of think about assessments and services for. And so example is selective mutism in the line provided. And again, you know, having pediatrician, medical director kind of looking at these from face validity. And again, in working with the Center for Healthcare Strategies team that reviewed the metrics, these were things that didn't not pass a validity of, like, that actually could be, for those who know young children and know those factors and how they relate to other outcomes and how you might think about serving them. There were people who felt like these are appropriate services to include, but again, we're noting where they are on the prioritized list. So to go back to the question, for number one, in terms of the diagnostic pairings and including them below the line or not, I'm curious to hear from folks about their thoughts on that. So maybe what we could do, knowing this isn't holding you to like, this is our CCO's final answer, although I would love to get from all 11 your final answer on this. I'm just curious, so if we did a thumbs up of if you think it should be included, can you use the now I can't find it. Do you guys have it on this, Elena? Do you have a thumbs up?
Yeah, it's a reaction.
Okay, I don't think I can see it because so if you think it should be included, if you think those handful of codes that have a diagnostic pairing that's below the prioritized list but is valid and important, if you think it should be included, can you give me a thumbs up on your screen if you're able to? Obviously, if you're on the phone, I know you're not able to, but if you think it should be included, can you give me a thumbs up? Thank you, Susan. Got it. Anybody else want to put their vote in? Knowing, again, you'll have time. Is there anybody that is like, I don't think it should be included and this is why? There's not a, oh, Tanvir saw your vote. There's not a down button, right? On the reaction, there's only a thumb up. Okay. What would be another reaction we could do to make it easy for people that don't like talking on group calls that would indicate, I don't think we should? What do you think, Katie? Is it a clap?
There is a surprised or shocked face, as in I would be horrified if those claims would be included.
If you are like, I'd be horrified, that's a strong word, but like, I'm inclined to not include, use the shocked face reaction. Nobody shocked face?
No, but we did get some other thumbs up votes that came in the chat from Stuart and Matt.
Got it. Okay. Thank you, Stuart and Matt. Okay, let's go with provider taxonomy. And I guess I haven't told you our team's recommendations. I would say with number one, our team, if I think about OHA broadly, CI, and OPIP, our team is split on issue number one, which is why your 11 CCO votes really matter to us in terms of understanding this, and then public comment on this is really going to matter. For number two, in terms of including list 2 and list 5 that require provider taxonomy, there's include and there's not include. I would say our team in general is supportive of including them because we think they represent really, really, really important services. List 2 and list 5 are not the places you're going to start in terms of trying to improve your reach metric, but they're really important things that we personally think should be included. But this is a public process. So if you think that list 2 and 5 that require provider taxonomy, knowing the pros and cons with that should be included, give me a thumbs up. Or put it in the chat if you're not a thumbs up person. Got you, Drew. Thank you.
Drew, Stuart, Rebecca.
Callie. Okay. Is there anybody that's like, shock face? No, I don't want you to include them. So it's the, what's the symbol look like? I don't see any shock face. No strong feelings about taxonomy, huh? Okay. All right, super super helpful. Again, you know, our next webinar is in March, but you have the email of the team. So you as a CCO pilot, if you have additional context, background you want to give us on these factors 1 and 2, we really want to hear your perceptions and your voices on this. We're going to be outlining CCO's thoughts on this. We have documented, again, people's feedback today as one piece of information in this conversation. Okay, so again, the purpose of this component of the measure is really to give you information to kind of inform the kinds of activities in the attestation work that are the backbone of the metric and the backbone of, if you do certain things, would be aligned with transformation funds. And so knowing that we see it as part 1 of the journey, that we see it as part 1 of galvanizing and forming conversations, knowing that in our proof pilots and in the work that OPIP has done, this data has been invaluable in various communities and kind of understanding what's happening for children now, what resources exist for children, and how do we think about bridging that gap, and how do we create family-centered, person-centered approaches to get children into services that improve access for all children, but in particular, think about access for children with historical and equitable outcomes. So we wanted to just make sure in the last part of this webinar that we just opened it up with kind of, as we're thinking through this metric and kind of all the thoughts that you heard went into it, is there any other information or context that you think would be valuable for us to understand or hear from you relative to the social emotional reach metric? Have you guys, as you're thinking about, okay, so this would be the start. In the future webinars, you're going to be talking to me about how the attestation is actually tied to using this and doing other activities that engage my community and address some of the barriers that are anchored to what you've learned in the past. Is there anything else we could do or any comments and feedback you would give us about how to provide this in a way, if it were provided at the beginning of the measurement year, in a way that would be helpful to you and we really help align with the intent of it, which is it's meant to be meaningful, relevant, and useful. And then again, I know with your other metrics that the incentive money is tied to whether you improve or not. That validation process is really, 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 really important. So we want to learn about this metric. We want to learn how it works. That's partially why we're proposing the system level metric and not this to be tied to payment. So we want to just understand the timing of the validation work, given you guys have a lot going on. And so some of our team thought, well, maybe it wouldn't be good to put the validation work of this incentive, of this measure, timed with the validation measure work you have to do with other measures for which those are tied to actual performance. So does anybody on this call, knowing that there's a lot of you, have any feedback, input that you'd like to provide to us on these 3 points? So 1, further information or context that you think would be valuable for us to understand or us to provide to you about this measure. We're happy to, as you probably can tell, this has been a pretty thorough, deep process. So love to give you any other background that would be helpful. 2, do you have any input on like how you might use it and what we could do to be helpful to you? And then 3, any thoughts about this kind of like helping us learn how to make this work better, which I understand that term is validation when you're talking about a metric, and just the timing of that relative to the other things that you have going on. So what are your thoughts on that?
Colleen, this is Andrea from Pacific Source. One of the thoughts that I had when you were asking about above the line, below the line, diagnosis and should it or should it not be included. One of my thoughts was, given the importance of some of these diagnoses and the impact on a child's life into adulthood, is there any opportunity to do some upstream work? And if these diagnoses are that impactful, could the committee that makes those decisions get those above the line? So then they are, it's hard to ask providers to do work on something that they're not going to get paid for. And I know that's a struggle we've had on all sorts of different topics, but that was just one that really kind of hit, for me of, is there any upstream work that can be done to get those diagnoses above the line if that's what we're going to include into the greater metric?
Yeah. As you know, some of that work happened in terms of the upstream work related to developmental screening and some of the services that hadn't been covered that you guys, I know your CCO decided to cover because it was the right thing to do, even though it wasn't covered. I think that's really, really helpful feedback to share with our Oregon Health Authority partners. Again, this is a pretty deep collaboration and partnership, and also moving things on a prioritized list is also an extensive process. And so I can make sure to share it given the alignment of this work with Raise Up Oregon, with governor priorities, and with a number of other efforts. And so I appreciate that feedback immensely, particularly if you think about this measure being tied to the system level measure and then thinking through some components around that, about how we could think through some of the policy levers there. So I will share that with our OHA colleagues, and I think it's a great idea to put as a kind of component of the system level work that maybe the system level leaders could do to support the CCOs in doing the system level work that you would be doing as part of this work.
Thank you.
Colleen, it's Susan Fisher-Mackey from All Care.
Hi.
Hey, so for everyone on the call, I will always defer to other teammates from All Care when it comes to diagnosis codes and the data system pieces. I come from the early care and education system. I shared with Elena in a private chat, I'm a little concerned about the acuity. I think what we see downstream from our school professionals is really that, yes, there are these children that are living with very acute realities and health conditions that the medical system can help. But by and large, the children that show up dysregulated and unable to achieve success in kindergarten, they're not on the radar. These are not behaviors or pieces. And so I worry, and I guess I just like the group to finish or to continue to hold in mind, because I know this was a big part of our work with Hacker, that how do we make this not just something that's going to those really acute cases, but this becomes a preventative universal effort? Coupled with that, really my thought is the diagnosis codes and all those discussions are really what data gets counted and can be counted is really important. But I think the true impact on the system that I'd ask this group to hold in mind is the second piece, the community asset mapping and thinking downstream about how we prepare for opening the floodgates on community-based organizations who actually have the bandwidth and the skills to provide evidence-based, best practice, culturally responsive services to nurture children and families towards higher social emotional capacities to prepare them for school success.
Susan, thank you so much for your comment. I really want to make sure that I actually clarify something, because I don't know if I would agree with the statement that the metric is narrowed to only kids who have conditions. The assessment component of the metric, those assessments are aligned with Bright Futures recommendations of assessments that should be done for all children. And part of the reason that kindergarten teachers are stuck in the situation where a child shows up, not able to self-regulate, not able to kind of have some of the social emotional skills, is that at a breadth and depth at a community level, we didn't identify them early, but also in the over 800 stakeholders that completed the survey, I could do early identification, but when those kids needed brief interventions for the risk factors that are associated with the self-regulation that you're talking about, I had no brief interventions to give them to build their health and resilience. So if we were only doing a measure for children that had extreme diagnoses, what I think I hear you saying, the tip of the iceberg, we would be doing lists 4 only, or it lists 5 only. And so I just really want to, and I will tell you in terms of the services, that's a small component of the claims. And so I apologize that our work hasn't clearly articulated honoring what we heard from you as a member of Hacker, and also honoring the opportunities to support the important early learning providers that you're talking about in terms of the breadth and depth of community catch and community services. And so the measure is meant to be also including those things that would be appropriate. But if you look at a number of those diagnoses, they're actually aligned very much with your feedback of not being diagnoses of like the one we gave of selective mutism, but actually at risk because they've had adverse childhood event experiences. And so that component of the assessment was intentionally aligned with early prevention, and the component of services, particularly in list 3, that is really around brief interventions, engagements, connections to early learning services, which would be possible in an integrated behavioral health service. That was intentionally meant to not go down the pathway of just kids with extreme issues. So it really, the REACH metric does actually really include a broad array, knowing that actually our stakeholders might have said to only do the services because they felt like services aren't available for those that we identified, but we wanted to make sure we were honoring that broader feedback. So I really, really appreciate you commenting, because I'm just really glad we had that point of opportunity for clarification. And I think some of the exciting stuff that CCOs can explore is there are a lot of opportunities for these claims to be built by the very partners you're talking about. Now, whether those partners are currently doing that or not, but there's no policy payment barrier that wouldn't allow for that. So I think, you know, there's going to be a bunch of different approaches that need to be anchored to your community strengths and your community attributes and your community resources that you have, which is why I love that you brought up the asset mapping in terms of like, what are the strengths in the community? How do we build off those strengths? How do we get children to those strengths, knowing that they're in a breadth and depth of settings? And how do we allow people to feel safe to identify those children early and to think about how to normalize this conversation about social emotional health so that we can start to kind of evolve that landscape? And so I appreciate you bringing up the attestation component in terms of the asset mapping, because that is the goal in terms of bridging the gap between given where we are and given where we need to be, why there has to be a cross-sector approach.
Colleen, this is Jean from EOCCO. I want to add to, I'm sorry, your name was Susan that just spoke?
Yes, it was.
Okay, thank you. When she was talking, I thought, yep, that's exactly where I was going to go in some ways. I think the first year, like you said, we won't be expected to reach any metrics or we're going to be gathering information. But I know a lot, like you said over and over, that OHA, this is a huge collaborative effort, and a lot of energy and time and money has been put towards this. And I don't want to lose focus or lose the fact of what you just said, normalizing this, Colleen. We still have a lot of work to do in the public with public awareness, and piggyback on what 0 to 3 does for campaign awareness and public awareness of early detection, early intervention, and the benefits of that. Not many people have access to 0 to 3 in their website, although they make it accessible. And I'm thinking of recently the public awareness that Oregon is doing around social distancing, those little catchy commercials that they're doing, that in order to have an impact here, because I've been working on this for many, many years, it's still in that feeling of little people, little problems, and we can pick them up and we can handle it and it's okay. And well, they're not that bad. And, you know, developmentally, parents are told by their doctors, well, let's just wait and see, because some developmental milestones do work themselves out. But what we know in trauma, with trauma, is they do not. But that same mentality is still being thought of with little ones. And let's just wait and see. And the trauma doesn't go away. It's actually better to tackle it early on. And there's still so much work to be done just in that public awareness effort to increase the numbers and have people say, yes, I will take that referral, and yes, I will go, and I will not wait and see. And so if it can be done in conjunction with this metric in 2023, when there will be some numbers attached to it, I think we'll get the best bang for our buck and moving this forward.
Thank you so much, John, for your work and just your statewide leadership. I know this is like your personal passion, and you have lived experience about what has worked and barriers you've run into, and I appreciate your voice. You know, that's the whole point of this metric. I mean, we remember the data at the beginning. Despite years of early learning efforts, despite a number of important components, we're not seeing some of these things happen. We're hearing exactly what Susan talked about in terms of kindergarten. So again, in year two, the current proposal is not that the incentive money would be tied to improvement on the REACH metric, even in year two. We will continue to be collecting and providing the data. I think, John, exactly what is proposed is exactly an opportunity that you could decide to take as a CCO for improving the rate. So the reason we're giving the data overall, and the reason we're giving the health complexity data, is to bring the very point that you're talking about, which is that in your region, when you engage your community level partners, there is a group of children that we know have exposure to things that would be, I mean, all children deserve a social emotional health assessment, because that is a core component of their development. Just like they deserve to be weighed, they all deserve to have their social emotional health addressed. It is a core component of who they are and of their development. So, you know, a way that USCCO may decide to approach this isn't a public messaging campaign. I think that I can see the value of that. I can see the value of other communities taking different approaches. And so the purpose is actually in the attestation metric to allow for, again, addressing some of the root causes, also being aligned with the intent and purpose of what a CCO incentive metric is, and the kind of round peg that we have that is the incentive metric versus other strategies. And so that was part of the reason, to your point, why we worked with, and I'm so thankful that the Health Authority agreed to give some of the health complexity data, because in the proof pilots that we've done in communities, when you start to show that data for those people in that community and say, how can we work better together to kind of make sure that all children really receive a social emotional health service that's normalized, but also recognize that there are children that we don't need to wait until they have a diagnosis or wait until they don't thrive in school. There are children that have had experiences that would benefit from an assessment at a minimum, and likely from the kinds of reimbursable behavioral health services that I know that you've worked on. So I appreciate the kind of input and guidance that you're giving of, as somebody who's been working on this for a number of years. There's a stigma issue here. There's a public health awareness issue here. And I think if this were to be adopted, one of the benefits of the system level metric is to allow for creative level approaches at the community level for how you might kind of address some of those factors in the community, and to actually give you actionable data to inform those conversations, knowing that they're going to be multifactorial, and knowing that the strengths and assets that you have in that community. So what Susan has in her region versus what you have in your region versus Andrea, what you have in your region, those strengths are going to be different, and you can't know how you're going to bridge that gap until you know what resources exist. And that's the purpose of the cross-sector component. So I really appreciate you sharing your learnings, and also hope that this kind of illuminates how these are meant to be tied together in terms of helping to inform some of that community level conversations and public health awareness that I hear you saying is important. And I definitely can understand that. I can't see the chat because I went to move the
Yeah,
thing.
I
Is there
wanna
any other
elevate-
questions? Sorry. Okay.
I can elevate some exchange that's happening in the chat. So Susan from All Care has asked if family stability assessments, so looking at the ecosystems in which kids are being raised, which are indicative of social emotional health outcomes, are those included in the lists? Lydia is following up to ask what specific codes so that we can double check and ensure that they are. And Susan will circle back with us when she connects with her colleagues at All Care. So Lydia is just affirming, we think it's really important to capture any social emotional health touches that are happening globally, and knowing that lists 1 and 3 don't require a paired diagnosis. So we should be able to capture those codes.
Yeah, so just to give an example, Susan, some of the initial interventions that are included in list 3 would be things that like integrated behavioral health or other would do to understand the family dynamics, which we know are drivers to social emotional health. I'm not aware of just personally any claim code, again, given lack of clinical recommendations and just given CPT codes of any one that is currently being used to that, which is why we were kind of going to this other part. It's also why, again, we're trying to raise the social complexity data in terms of providing it as a tool, not only at a CCO level, but kind of thinking through at a community level. Any other questions, Elena? I'm sensitive that I need to pass it to you guys.
No, I think this conversation is also just elevating, though folks aren't responding specifically to this first question of what further information or context might be valuable in kind of understanding and digging into this data. It sounds like that we could do some additional framing or information sharing around how the assessments and services included in the metric really do capture a full range of social emotional health supports, starting with prevention and promotion and going all the way to treatment, just so that as you're engaging with folks on your CCO teams and community partners, you have that language to be talking about the REACH metric data as well.
Okay, last call for input.
I just want to acknowledge, I know that not everybody is able to process and respond to questions in real time. And so somebody asked in the chat if we can send out questions ahead of time so that you have time to ruminate on them. And we can definitely do that in the future. Thank you.
Lena, this is Tanvir. I would just say that, I'll be pretty transparent. I just downloaded that Excel spreadsheet as the meeting was progressing. And we did change over with OHA from our business objects and it was my first time that I've really logged into this SharePoint site, which is far more friendly now. But I needed to make some loops and hoops. So eventually I did see the file. So we will be looking at it in our team. The team would be probably led by quality, but we'll have our decision support analysts work with it. And then I'll be sharing the file pretty much with our behavioral health folks and a couple of other departments which have been actively participating with meetings with Colleen as well. So yeah, we will do that. And so it's too early. We haven't really analyzed the granular data, but we'll have a lot of questions, I'm sure, coming out of it. Yeah.
Thank you, Tanvir. Yeah, we would love any additional thoughts, questions, feedback that emerges as you dig into this data. Several folks have also asked if we'll be sharing the slides. Yes, we will be emailing out these slides and we'll also post them as well as the webinar recording to our website. So we'll make sure that you have the link to that and receive the slides.
Okay, so Elena, I will pass it to you and Sarah to talk about what's next.
Yeah, so this was our first of 3 webinars. And so our next webinar is really going to be focused on digging into the attestation, which is the broader metric. As Colleen shared a few times on this call, the REACH metric is a really important component of the overall attestation. And so what we're proposing for this metric is that the financial incentive be tied to the attestation itself, not to making specific progress on the REACH metric data in the first few years. And so Sarah, would you like to share anything in particular that we'll be digging into in our next webinar on the attestation?
Sure, and I also just want to acknowledge we heard that it would be helpful to have the materials prior to the call, which I think will make the call a whole lot more productive for all of us. So that's what we're shooting toward, would be presenting to you and providing you with the draft attestation tool or metric that on the 18th, we would also walk through with you so you understand, kind of as Colleen did with the REACH metric, some of the background on why we went specific routes on gathering information and really trying to find that balance. And we'll want your feedback on, what are the most effective ways to operationalize the measure and the attestation, and gaining your feedback, as well as balancing that with what OHA will be looking at ultimately when you report the attestation. So that's what we'll be doing on the 18th, is getting your reactions to the initial drafts, hopefully in enough detail that we can make revisions, or at least be able to regroup to assess the need for revisions. Get your feedback on where more clarity would be needed in any components that we have drafted, and really just talk collaboratively on what we need to do to achieve that balance and drive this metric forward, because the big pieces of this are, as were mentioned earlier, the asset map and then some action planning in order to improve infrastructure.